just a very little bit on this. Next is if your patient has a previous illness. So now we are moving into the secondary causes of things that are complications of preceding illnesses and are henceforth causing shortness of breath. So this is a different category. So this is going to be your patients who are not even just risk factor patients, but also they already have preceding illness. So for example, a patient who already had pneumonia and you diagnosed them with pneumonia a few days ago, and although they were taking medicine or they may not be taking any treatment, and all of a sudden they got much more profound shortness of breath. So you should definitely think about pleural effusion. Another way to think about this would be a patient who's already been given treatment for pneumonia and they just are not getting better. You must think about pleural effusion by doing a chest x-ray or doing a proper physical exam. So parapneumonic effusion is quite common. Then there are other causes of pleural effusions. For example, patients with rheumatoid arthritis or lupus or any interstitial diseases or connective tissue disorders can get spontaneous pleural effusions. Patients can also get malignant pleural effusion because of lung cancer, because malignant cells can start to cause effusion. So there are many other things that can cause pleural effusion, but usually these patients are already sick, and they have decreased exercise tolerance, they have fatigue, they have shortness of breath. They don't necessarily have fever because it's either already resolved or their etiology for pleural effusion is not infection. So like I said, these are some of the risk factors. TB patients can also get pleural effusion. So the diagnosis will really largely rest upon your exam. So physical exam, you will look for these risk factors, but of course if these are present, you can see most of these risk factors in themselves can cause shortness of breath. So don't be distracted and say, okay, maybe this is just the same pneumonia that the patient is just recovering from and has shortness of breath. Always look for the degree of severity of shortness of breath, and if it's not consistent with your assessment, clinical assessment of pneumonia, then definitely look for pleural effusion. So these risk factors, you can see they can cause independently shortness of breath, but now the patient has gotten worse and the patient has degree of shortness of breath out of proportion to these illnesses, and when you do their exam, they have decreased breath sounds on one side, they have dullness on percussion on one side. So definitely you will think about pleural effusion. And when you do the chest x-ray, it will be it will be clear, and you will you can go ahead and draw a pleural fluid, and the fluid will show that it's either transudate or exudate, and you can analyze it and then treat it accordingly. So this is a chest x-ray. We saw a similar one before, so that was parapneumonic effusion. This is again pretty big, large left-sided pleural effusion that's obliterating the costophrenic and cardiophrenic angles. So it's cardiophrenic and costophrenic angles, and you see all haziness here. Another very large effusion on the right side, so you can see there is all fluid right here. Next one is again shortness of breath in the setting of a prior illness, for example myocardial infarction. So these patients, after day 2 or 3 or even 4 of MI, they all of a sudden they start to develop shortness of breath, and it's usually out of proportion to their previous clinical picture. So they just become more acutely short of breath, and in that case you must start thinking about pericardial effusion or tamponade. So again, these two things, effusion or tamponade, are causes of shortness of breath, and they can most commonly occur in the case of recent MI, but they can also happen with independent problems, and we'll talk about that here in a second. But again, these patients have very similar clinical picture, decreased exercise tolerance and fatigue, and the risk factors are either MI or they might have just received radiation treatment for cancer and it's causing pericardial effusion, or they had a connective tissue disorder that's causing lupus, rheumatoid arthritis, or things like that. So remember from our cardiac causes of shortness of breath, where we had restrictive cardiomyopathy that was causing shortness of breath because of diastolic dysfunction. These things were there, right? Lupus and rheumatoid. So these patients can actually develop pericardial effusion, pericarditis, restrictive cardiomyopathy, diastolic dysfunction, and finally shortness of breath, all because of all that. So that's how you recognize these things. On physical exam, again, you may not see too many lung findings, but you will see that the patient is tachypnic and hypoxic, possibly. And then there will be pericardial rub if you examine cardiovascular system. If they have pretty big effusion, they may actually have displaced PMI, so that's a possible finding. Chest x-ray will basically tell you that there is effusion present if it's large enough, but echocardiogram will be the definitive test. So here you can see there is a pericardial effusion. It's hard to tell here if it's pericardial or pleural effusion, but the cardiac shadow is pretty globular here. Here is the big pericardial effusion on echocardiogram, and you can see it's all fluid, and that's how you can tell. And it's effusion actually all around. So these patients actually have very weak S1 and S2, so that will be another thing to keep in mind. That's how you can tell maybe they have pericardial effusion. Another CT scan, you can see there's a lot of effusion right here around the pericardium. So next would be if your patient is already in the ICU or hospitalized and now they have got acute shortness of breath. So another thing to keep in mind in that scenario would be ARDS, or acute respiratory distress syndrome. So your patient will be hypoxic. Basically you will need to put oxygen on them, but of course don't stop at that. Try to figure out why they are hypoxic. They will not respond to supplemental oxygen very easily, so that's how you start thinking, okay, maybe it's ARDS. Risk factor, again, hospitalization is usually, so it's basically just alveolar edema. That's what causes ARDS, and it's usually because of inflammation or a widespread illness in the body, sometimes in the setting of sepsis. That's how they get ARDS. Acute pancreatitis can give rise to ARDS too, and there are many other critical illnesses. That's why the patient is in the ICU and they go on to develop ARDS. Again, they don't have too many other exam findings. They just have tachypnea and hypoxia, and when you do their tidal volumes, they are usually low. This is a hospitalized patient with a huge amount of alveolar edema, and that's how you know this is ARDS. This patient is definitely very hypoxic. Next is again shortness of breath, where you are thinking that okay, there's one very common cause of shortness of breath, but this I have to keep in mind is a diagnosis of exclusion. So what is it? It is anxiety. So panic attacks or anxiety disorder can cause shortness of breath, and usually it comes in episodes. So this is a combination of things that people present with. So they have chest pain, palpitations, numbness, and tingling. So remember that this shortness of breath is going to be much episodic, dramatic. Patient will have a feeling of doom. So this is an anxiety panic attack, but it's very important to make sure that we are doing it as a diagnosis of exclusion. So don't just label anybody, even if they fit the classic picture of anxiety disorder. Don't just say this is anxiety. You gotta rule out other things first and then finally make this diagnosis. So what are the risk factors? A history of anxiety disorder in the past would be a risk factor. History of panic attacks in the past would be a risk factor. But also, this is another important point to keep in mind, that a previous history of anxiety disorder doesn't mean that this particular attack of shortness of breath is also anxiety. So you always have to be very vigilant. On exam, these people are usually hyperventilating, and so by the way they are hyperventilating, you can usually tell that this is a panic attack. And they have a very normal oxygen saturation when you check it, so that will be another identifier. If you do draw their ABGs, they are usually normal, or it may even show hypocapnia. We don't usually have to draw this, but we can. Chest x-ray, of course, will be normal. All the labs and tests would be normal if we do them. Alright, so now we move on to the chronic causes of dyspnea. So remember from the very first couple of slides that chronic causes were parallel to acute causes, so usually dyspnea of longer than 4 to 8 weeks duration. So I am not going to talk about details because it's exactly identical slides, except for all these things now are happening for chronic time period. So these people usually, they are not very severely ill. They have mild dyspnea, that's why they don't present very quickly, and they have gone on with these symptoms for a while. But on symptoms and risk factors, and as far as the signs are concerned, all these things are going to be exactly the same. They may not have chest pain as much. They may have a mild degree of all of these symptoms, and their signs may be normal. So that's just cardiac. So this is just to show that cardiac ischemia, it doesn't have to be acute cardiac ischemia. It can be chronic stable angina. That's what will present as chronic dyspnea. Then again, chronic aortic stenosis can present with longer duration of symptoms, and in this case they don't usually have syncope, so that's the difference, but the rest is all identical. So they have all these risk factors, very mild symptoms, and when you evaluate them, that's how you know it is chronic aortic stenosis. Patients with heart failure, again, usually these patients have longer duration of symptoms, because although they may present early on with acute symptoms, with acute exacerbation, but even after you treat them or you've seen them, they don't usually, remember, heart failure does not get cured, we only manage it. So they don't really completely get treated unless it's a very acute, like infective endocarditis type of picture. So they are going to continue with symptoms, and these symptoms will become their baseline symptoms. So they have baseline mild shortness of breath. Depending upon New York Heart Association classification, it may be class 1 or 2, but they do have baseline chronic shortness of breath. When they present with acute symptoms and it's gotten really worse, then we call that acute exacerbation of heart failure. So that's how you keep in mind, but the rest, everything is identical. Again, AFib patients, so typically atrial fibrillation patients present acutely, so they do have acute symptoms, especially if it is fast heartbeat. But if it's a rate controlled AFib and they are not really very sick, don't have too many symptoms, they don't bother to present. So they may not come see you, they may just have symptoms for a while, and finally when you do their exam, you know it is AFib. Again, patients with COPD, so in the absence of exacerbation, just a stable asthma, chronic bronchitis, emphysema, these patients have all these symptoms, usually not as dramatic. They don't have hypoxia, of course, they don't have wheezing, but they have very mild cough and shortness of breath and phlegm, and it goes on, and then in between they can get acute attacks and exacerbations, so they may have chronic symptoms as well. Again, anemia patients can present chronically with chronic symptoms, so just keep that in mind. And this again will be, the hemoglobin usually is not very low, so that's how you know it is chronic, or the symptoms will be mild. So the next is another category which we have not talked about yet. So patients can present with shortness of breath. Usually it is chronic, so it's longer duration, but it can be acute as well. Most of the time the shortness of breath has gone on for some time because it's not very severe, and we will consider lung cancer or abscess under these circumstances, when abscess will be usually acute, less than 4 weeks, but patients have shortness of breath with really high grade fever. And lung cancer patients usually have chronic shortness of breath, so because they don't start to develop parenchymal problem right at the onset of lung cancer, they usually have a prodrome or a certain duration of cough and weakness or things like that, and then they eventually develop shortness of breath, and it is mild in the beginning and then becomes severe. So again, lung abscess patients usually have chest pain and fever. That's how they present. Lung cancer patients usually have chest pain and weight loss. So whenever you see a patient who has relatively long duration of shortness of breath with cough and fever, then definitely if it's relatively short duration with cough and fever, then it is then you got to think about abscess in the presence of other risk factors that we'll talk about. If a patient has a relatively longer duration of shortness of breath with chest pain and weight loss, then in the presence of some other risk factors such as smoking, then we definitely want to think about lung cancer. So they have progressive dyspnea, they have hemoptysis, so both these patients can have hemoptysis. They both have cough usually, and weight loss is present in lung cancer. Risk factors for abscess would be recent lung infection. So lung infection untreated, like we saw in the case of pleural effusion, untreated pneumonia can turn into pleural effusion. Just like that, untreated lung infection can turn into lung abscess. Classic patients are going to be your alcoholic patients or patients who just have a neurological dysfunction and they aspirate, and that's how they present with lung abscess and all these findings. Risk factors for cancer would be history of smoking, older age, and family history. So those are the big 3 risk factors. Unfortunately, they are very similar to many other risk factors. Risk factors for many other cancers, pretty much all cancers in the family, in the body. So that's how these become high yield questions as far as social and family history is concerned. So whenever you're suspecting lung cancer, make sure to ask about smoking and family history too. Alright, so on physical exam, your lung exam will be very variable. So there may be some extrapulmonary manifestation of lung cancer and so paraneoplastic findings. So you may want to think about those, like Horner syndrome and things like that. Or it may be a completely normal exam. But when you do the chest x-ray, guess what? You can either see the abscess or lung cancer or a nodule, and its chest CT will definitely diagnose a lung cancer or an abscess. So here is an abscess. You can see there is a left-sided abscess and there is an air fluid level. So this patient is pretty sick with cough and chills, and there is a very irregular mass in the left middle lobe. So that's how you know this is cancer. This is another lung nodule. So this nodule can be benign, but it's fairly big. So when you do a CT scan, you find out this is a lung cancer with some hilar lymphadenopathy. So another lung cancer or lung mass on the CT scan of the chest. Alright, so the next is a patient has chronic fever, chronic shortness of breath for quite some time, and they also have weight loss. So in addition to lung cancer, we should also think about tuberculosis. So these patients usually have cough, fever, and weight loss, and some risk factors. So that's how you think about TB. And we already talked about TB in fever, but we'll just touch upon it here too. So these patients usually have progressive dyspnea and hemoptysis. Usually cough is productive and it has blood in it too, and they start to develop weight loss and fever and night sweat. So these findings are very similar to cancer, with the exception that they may or may not have history of smoking. So usually smoking is not going to be a risk factor, but they may have a history of travel, or jail patients usually develop tuberculosis too. HIV patients can get secondarily infected with TB. So whenever you see somebody with TB, you gotta check for HIV. That is extremely important. On exam, exactly the same exam findings. This is a typo here. They don't have extrapulmonary manifestation of lung cancer. They actually have extrapulmonary manifestations of tuberculosis. So they may have some extrapulmonary TB findings. So sorry about this typo here. They may have variable lung exam or a very normal lung exam. And the test to do when you're suspecting this would be chest x-ray and CT scan. And if you see a spot on the chest x-ray, you gotta do either a T-spot or tuberculin skin test, which will be positive. But usually it becomes positive after a long duration, so it's not going to be positive in acute setting. And of course you gotta do HIV test. So this is a patient with tuberculosis. You can see right upper lobe is involved. The next is our patient with dry cough. So they have dyspnea or shortness of breath for longer duration, and now they have developed cough. So that's interesting because now they don't have any productive cough, so we can say maybe it's not an infection or tuberculosis or anything like that. But what else can it be? So dry cough, if that was your next question after you've checked for chest pain and cough and fever and other things, now you're asking about dry cough, and the patient says, yeah, I actually have cough, but I'm not able to produce any sputum. And it has typically, this goes on for a long time. So this is usually your longer duration chronic dyspnea. So patients, you're going to think about interstitial lung disease, and you are all familiar with interstitial lung disease. These cause a restrictive pattern on spirometry, so they are going to be short of breath because of it, because it is a parenchymal disease. So what are some of the symptoms of interstitial lung disease? So they may have a rash. So a lot of the times these people, the most common finding is a rash, a skin rash like in lupus or rash in other disorders. If it's a rheumatoid arthritis patient, they may have joint pain and inflammation. Sarcoid patient usually has is African American, and they have chronic findings like sarcoid nodule on the skin exam. So sarcoid nodule is is a key feature here in this setting. Risk factors would be that they have a previous family history or a previous personal history of autoimmune disease, so they may develop some autoimmune disorder early on in life, and now they have developed interstitial lung disease. But this is not always going to be present. Family history is usually present, so just keep that in mind. Again, there may be some variable lung exam, and there may be extrapulmonary manifestation of interstitial lung disease. So, for example, if you are thinking about sarcoidosis, they have skin nodules. If you are thinking of rheumatoid arthritis, they have morning stiffness and joint pain. Lupus patients have a whole host of different things, so it's pretty much all the body can be affected. And of course, your labs and tests would be chest x-ray, chest CT. You're going to want to do PFTs on these patients to see if there is a restrictive pattern or an obstructive pattern, and that's how you make the diagnosis. And then you can do specific tests for all these disorders. This is a chest x-ray showing interstitial lung disease, so there's a lot of interstitial markings here and infiltrates here, so you that's how in the setting of rest of the physical exam and history findings you can make the diagnosis. Alright, so now we are moving on to the more obvious causes of chronic causes of dyspnea. So we are almost getting there. So this is a patient with pregnancy, so you already know a patient is pregnant. It will be obvious in the second and third trimester especially, and the patient is short of breath. So the key here would be to make sure that this is just the pregnancy causing shortness of breath and not something on top of pregnancy. So that's something to keep in mind. So these patients are tired, they have decreased exercise tolerance. If they have any other symptoms present, for example, we talked about cough and chest pain and even weight loss and rashes or anything that we just discussed so far, then you should make sure that you are not dealing with those diagnoses, because of course pregnant patients can also get TB, they can get HIV, they can get cancer, they can get anything in the world. So this in a way becomes a diagnosis of exclusion too, so just keep that in mind. Usually excessive weight gain patients or patients with superimposed anemia have more shortness of breath, and then they have decreased lung volumes on the exam. If you do their PFTs for whatever reason, usually it's not needed, it's going to be restrictive pattern, and there's really no x-ray needed, actually should not be done, and the treatment is just supportive treatment. We don't really do too much with this. Then also another obvious cause would be obesity. So again, this would be your diagnosis of exclusion. Don't just blame everything on obesity, but obese patients are going to be more deconditioned. The key to ask, or the key question to ask would be if their exercise intolerance has progressed from their baseline, despite the fact that they have the same BMI. So if they have not gained too much weight during the time when they started to feel shortness of breath, then you should look for other things. But if they've been short of breath since the time they've started to gain weight, then maybe it is deconditioning and obesity causing it. On exam, they may have decreased volumes on PFTs, but the rest of the exam will be pretty normal except for high BMI.